I'm Dr. Prakhar Tiwari, currently a Senior Medical Officer in Jamshedpur, Jharkhand Government. Today we have with us Dr. Sneha Mukherjee, medical resident in medicine, and we will be discussing the topics like status epilepticus. And hello, welcome, ma'am.
Okay, so today as my topic is status epilepticus, I just want to inform you that this case is actually, the scenario basically about status epilepticus is very important, especially as a physician and especially in emergency medicine as well. I mean, we do see a lot of cases every now and then. I think especially whenever we have duties, we do come across these such cases very often. So to start off with status epilepticus, I just want to give a small case scenario which I came across a month back. So it's about a 17-year-old girl who presented to me in casualty with a history of altered sensorium as well as involuntary movements since afternoon. So it was a Sunday afternoon when she was throwing like these involuntary movements she was having since afternoon. So when I saw her and when I checked all her vitals, everything was normal. Everything was fine. Her BP was fine. Her saturation was normal. Her heart rate was about 80. Everything was fine. But she had this proper GTCS, what we call as generalized tonic-clonic seizures with uprolling of eyes and frothing, and she had a bite on her tongue. But when I saw the patient, usko dekhe aisa lag nahi raha tha ki, she seems like a normal, like a patient, so I couldn't make out that she has a microcephaly. So I knew that I have to, dig deeper into the past history. So when I spoke to her brother, I got to know that when she was born, she had meconium staining, and after which she started having her first seizures as a newborn. And from the second month of her birth, she continuously throws seizures every now and then. So the history goes by that she used to have one episode of seizures in 2 to 3 months span, and she was on continuous treatment of phenytoin, tablet phenytoin. And when the things used to aggravate, she used to go to a close by PHC and used to get Levera injection, and it used to subside. So for that, it's like this treatment has been going on for about 17 years. So what happened actually on the Sunday afternoon was that she missed her treatment actually the Sunday morning. So when she missed it, she had one episode. And as the protocol goes, she goes to a nearby hospital and she tries getting Levera. Once Levera 500 mg was loaded and given to her, the seizures did not subside. And then she was referred to a higher center, which is to BLD, to my hospital, wherein we were like the tertiary care and we took care of her. So when she came to us, presented, as I told you, all the vitals were stable, everything was fine. But something seemed off. So when I opened her medicine the box, then I saw she was on phenobarb, she was on phenytoin, she was on quite a number of tablets, which was not told to us before. When I shifted her to ICU, she was her saturation dropped, so we had to intubate her. And then we started thinking along the line of status epilepticus. As the definition goes, that status epilepticus is something jahan pe the patients continuously throw seizures within a span of 5 to 10 minutes. Like previously in the textbooks, especially in Harrison and API, they have mentioned that it goes up to 30 minutes. But in the new guidelines, they say that at least 5 to 10 minutes of continuous seizures is determined as status epilepticus, right? So when she presented, she was intubated. We handled the ABC, the airway breathing circulation was maintained. After which, then we had started her as an acutely, since phenytoin was going on for her previously, we did consider that, and we started phenytoin as well. And acutely, we had given her Levera in the casualty, and we added as in Levera, phenytoin, lacosamide, all of this was started. But then it still did not subside. She still continuously through seizures. Post which we took a neurophysician opinion, and she said that let's start off Midas infusion. So when we started Midas infusion, automatically things got subsided, and then we termed this whole scenario. So this took about a day or so, 24 hours. And then we realized she comes under the super refractory period. So super refractory seizures, basically what we say. So status epilepticus is it's not as easy as it looks actually. It's a critical care. It's a very critical condition wherein, if you don't take acute treatment and if you do not take proper actions, you might lose the patient because of aspiration also. So yeah, this was a small case that I wanted to explain.
So when the patient came to the casualty, there had been a few lab investigations done, and lab parameters should be taken there, like ABG and all. So, ma'am, what were the abnormal lab investigations parameters that happen in post-epileptic patients that we usually see? Status epilepticus patient that we usually see.
So let's keep the investigations aside, so the first thing that I would think when a patient comes to casualty, what's the first thing that we check? First we use our hands. As physicians, we don't just go and start pricking the patient. First we use our hands. So we check the vitals, we check this and that. I mean the BP, we check the heart rate, we check the pulse rate, because we need to make out if there's some form of abnormality present or not. Now, as I had mentioned, vitals were stable. The next line of treatment I would go is for GRBS, because in hypoglycemia also patients throw seizures, right? So I checked her GRBS was 122. So that's the first thing that I would check for, as you said, in casualty base. Now, if you're saying the investigation that has to be kept in mind, now seizures can be of different types. As you know, there's GTCS, the generalized tonic-clonic type. There are focal seizures, and old terminology that's there, complete partial seizures or partial seizures. So in such cases, we have to keep in mind what type of seizure it is, the type, the duration, and if there is any pre-existing conditions, because I can't just think that the patient has hyponatremia and the patient will not throw seizures. Of course, he will throw seizures, right? So you have to keep all this in mind. So the first thing that you have to keep in, so the parameters that alter is hormonal changes. Hormonal changes also matter because there is excess neuronal activity happening. So there are catecholamines that are produced. So the patient will go into tachycardia because there's adrenaline rush at that point, right? So that's one. Second is the patient could also have prolactin activity because there's excess, as I said, there's excess amount of neuronal activity happening. So there will be hyperprolactinemia also in such patients. Also, you can also think that since the muscles are in strain, the patient is going to proper tonic-clonic seizures, right? So there is straining of the tissues, the straining of the muscles happening. So there is CPK, which is your creatine kinase, it is secreted. It is myoglobin that is produced into the system. As well as if you do an ABG, as you said, they will show metabolic acidosis with lactate increase. Because the muscles, as you know, myoglobin, the pyruvate, the urea cycle, urea increases, ammonia increases, as well as there's lactate also that is produced. So all these parameters increase in a status epilepticus patient post stage.
When we are admitting the patient to the casualty, and if we see any of these abnormalities, particularly if we see like lactic acidosis is there, should we start soda bicarb there and then or wait for the complete diagnosis and then?
See, giving soda bicarb will not harm the patient, but I personally would suggest that you try to rule out all the other parameters as well. Lactate will reduce eventually, but you can start bicarb. There's no harm in that. But in our setup, we don't start bicarb unless and until we can rule out all the other factors. Right, we have to keep other factors in mind, and post which only you can start a bicarb infusion, or else you can give stat doses also. But it's better to rule out. I would suggest that.
My next question is, how will you manage a status epilepticus patient in case of like what we usually see in hospital setup? What happens when the patient starts having status epilepticus at home? So what will you suggest to the parents and the family members there? How to proceed with that?
Right. So if a patient is throwing, so I wouldn't say, see, right now they would know if it's status or it's not status. It's just an epilepsy. Patient is throwing fit. Patient is throwing a seizure. So in the scenario that we work in, so in Bijapur, where I have seen patients, when they start throwing, so I'll give you actually a very funny story. I'll tell you right now. Yesterday, I had a patient. We were all sitting in the corridor, and there's one patient who sat on his chair, and he was staff of our hospital. He screamed. He had an episode of seizure, and he fell on his face. And he had a cut. Immediately when he fell, we all went and we started. Not me, actually, all the people around, all the attenders who were waiting in the queue for OPD, they went, and what they started doing is they started putting in their patient ke haath mein, they started giving chappal, they started giving key. So these myths that is there, and then they started doing all that. So then we as physicians, we were like, no, that's not the protocol. We actually told them, move away. We have to educate the family members, number one. We have to educate the society, number one, because it's a myth. The patient will be lying, aspirate, and he'll die. And then all these myths, it just leads to death, basically. So as you asked, at home, what do you do? I would say that the attenders first have to be educated that when a patient is having such an episode, the patient has to be first put in the left lateral position, and the tongue should be out, because there are chances of the tongue to fall back. And there's chances of aspiration. So these things have to be educated to patients to patient attenders who already know that the patient will be having. But if the patients who throw fits in the first go, they should be brought immediately to the hospital. There is no home care cannot be done for patients who have status. I feel so, because there are chances of complications. You have to keep an eye on these patients. Home remedy is not, unless and until if the patient can't travel, especially if they're handicapped or they're disabled or children or illiterate patients. We say कि मतलब home remedy also can be done, but I would prefer the patient to be shifted to the hospital because any complications can be handled at that point, right? So I would suggest home, not home.
Next question is from my experience point. When we first see any patient having something like epileptic episode, we usually start with diazepam or lorazepam. So as the initial anxiolytics there. My basic question is, do you use diazepam or lorazepam in the first 20 minutes of managing a status epilepticus? And which one is much better? Which one gives the much better clinical results? Because a lot of times, ma'am, the physicians are confused if it is diazepam or lorazepam or phenytoin or phosphenytoin first 20 minutes, according to we see the guidelines for status epilepticus. So, ma'am, which one should we start?
So
because
I am
this
glad.
always depends upon.
Yeah, I know, very honestly,
Yes,
I am
ma'am?
very glad that at least your hospital goes, at least you have made an effort to go at least for diazepam and lorazepam. In my hospital setup, we previously used to go for midazolam. Now I'll tell you the complications as such. So if you give midas, so I have seen many patients jahan pe patient has thrown seizures, we give 2 cc. This is the protocol. It just normally comes 2 cc, brother, 2 cc IV midas de do. We say it. Patient is shifted, maybe for CT or MRI or whatever shifted. Patient desaturates there because of respiratory distress and goes into intubation. So I'm very glad that you at least go for Lora. You consider Loraz or diazepam. So there's actually a saying there: if you have a venous axis, go for lorazepam, and if you have no venous axis, go for rectal or buccal midazolam. This is actually a dictum. Okay. So, but you are now giving me a versus of diazepam to lorazepam, but through the setup, basically that we've read, through Tripathi and all, they say that lorazepam is much better than diazepam. Why? Is because actually diazepam is a lipid soluble as well as the other one as well, lorazepam. But lorazepam is less lipid soluble. That is one thing. Second, the crossing of the blood-brain barrier is much effective in the lorazepam than diazepam. Okay. And accessibility of lorazepam is much easier than diazepam. So, of course, in any setup for that matter, we go for lorazepam than diazepam. And there are no complications as such. There is no respiratory depression seen with lorazepam. So, I would suggest acutely, yes, loraz.
Ma'am, this is a very good question, ma'am. Thank you for it. And we all were actually so much into saying which one should we prefer. If it is diazepam or lorazepam, this is the eternal debate that was going on in my hospital setup where I'm working. So we'll definitely start with loraz next time. And my next question, ma'am, is a lot of time we see the patient oxygen saturation is dropping down. So when do we usually require assisted ventilation in a status epilepticus patient?
Okay. So as I said, status epilepticus. Now let's go back to the story that I told you first, the case scenario of the 17-year-old girl. When she presented to me, she's absolutely fine. The status of the patient was very good. The vitals were stable. Why did she desaturate when she went up to ICU? Even I wondered why. Then I read through a little bit of articles and through journals, and then I realized that maybe she was in distress, number one, because there's so much of muscle that is being used. After a point, they get exhausted. So because it's excess amount of muscle straining that happening, that increases the oxygen demand. So the patient is in distress. The patient is in demand for oxygen. So they end up going into hypoxia or an apnea. Basically, what I'm trying to say is they go into apnea. So the patient needs, and then if you take an ABG that very moment, you can make out that the patient is going to metabolic acidosis. So in such patients, you have to maintain A, B, C. Airway, breathing, circulation has to be maintained. So, I mean, if you want, in short, it basically causes apnea, for which you have to, intubate the patient in such scenarios. But you have to keep an eye on the saturation. Never take it for granted that just because the patient's throwing seizures, the patient can't go into arrest. It can happen. I have seen patients, and it can happen. Doesn't matter. Age is not a factor. Just always keep it in mind that, whenever a patient is throwing seizures, always keep ABC in your mind. ABC has to be maintained no matter what.
Ma'am, my next question is actually the infusion of phenobarbital versus valproic acid. If we do the infusion of phenobarbital, that is 20 mg per kg at the rate of 50 mg per minute, and valproic acid is 30 mg per kg over 2 to 5 minutes followed by infusion. So, ma'am, if we go over this second step, first step was for 20 minutes. Second step, if the status continues for 20 to 60 minutes, we go for phenobarbital or valproic acid infusion. Valproic acid, ma'am, it is actually quite rare here, but I really want to ask that should we prefer phenobarbital because it has unfortunately a few years ago when I had just joined a person got Steven Johnson because of phenobarbital.
Right.
I have seen a case here. So phenobarbital versus valproic acid, ma'am, that is one of the questions that haunts me a lot.
So if you see the protocol, do you know the protocol that we follow for status epilepticus? Do you know?
Yeah.
No, I mean, it's okay. I am not questioning you. Just want to brief you. Yeah.
Actually, we had made a protocol after seeing the guidelines that we, for first 20 minutes, we have the status continues, then 20 to 60 minutes, then we have from after 60 minutes, if it is then we go for general anesthesia.
Okay.
So for first 20, we have diazepam, lorazepam, and all those things. Next 20, we have infusion of phenobarbital or diazepam or valproic acid or levetiracetam we have. Then we go for anesthesia. But nowadays, people are not generally into all those protocols.
Yes, because that now you are following the old guidelines. Basically, that's what I was trying to say, that right now the timing is so important. That's how that's why I defined status epilepticus is to be with 5 to 10 minutes. Now you're saying 20 minutes. Do you really think in 20 minutes you'll be able to subside the seizures as well as keep the patient stable? That's the main important thing that you have to keep in mind, because you have 5 to 10 minutes. It's a neuronal activity that's happening. You have to save the brain. That's the whole main point. That's why I wanted to stress on status epilepticus is not about 20 minutes. It's about 5 to 10 minutes. It's the faster you act, the faster you can save the neuronal brain cells. So as you asked about sodium valproate and phenobarbs, right? So actually, the thing is that if you know the protocol, 5 to 10 minutes, as you said, that you can start with any benzodiazepine. That is, I would suggest lorazepam. So lorazepam, then diazepam, midaz, not really recommended, but if you have it, fine, why not? Okay, so that is 5 to 10 minutes. After that, and you asked me about fosphenytoin and phenytoin. So after, if Loraz is not working, you can also go for fosphenytoin. Now we choose fosphenytoin over phenytoin. One is because fosphenytoin can be given in any form of saline. There is no restriction. But phenytoin, on the other hand, cannot be given in anything that has dextrose, because it acts with the drug interaction. It has a drug interaction. So you have to keep that in mind. So, and also the bioavailability of fosphenytoin, and you can give it faster. Basically, you can give it 150 ml per hour. You can give actually this one, phenytoin, fosphenytoin, I mean. But phenytoin, you can't do that. It has to go slow, and the toxicity is much more in phenytoin than fosphenytoin. So you have to keep that in mind. So so the protocol goes like lorazepam. If that doesn't work out, fosphenytoin. So that is between the 5 to 10 minutes gap. Now, if that doesn't work out, then we go, that's the first line of treatment. Then we go for the second line of treatment. What happens in second line? You can give levetiracetam, lacosamide, phenytoin, and sometimes they add midaz also to the second line of treatment. So that's the second line. If that doesn't happen between in the span of 30 minutes, 10 to 20 minutes, if that doesn't happen, then we go to the third line. Now, what is refractory? What does refractory mean? Is when the first line, the second line don't subside the seizures. Then we go for the third line. So what does the third line comprise of? Comprises of if you are propofol or midaz or thiopentol infusion. These three are the treatment of choice. If that doesn't work out, then we go for fourth, where we call the anesthetist, and we start propofol, ya fir ketamine. Now you're asking about sodium valproate. Sodium valproate actually is not available as such. So we use an alternate. So that this comes under the second line of treatment. All right. So sodium valproate. So in the book, what I have read is that sodium valproate is actually previously was the treatment of choice for any status epilepticus. And your phenobarbital is actually the treatment of choice for any generalized tonic-clonic seizures as well as focal seizures in previous. But right now, the protocol is such, they have changed the guidelines, they have changed, there are alternatives. So we don't have to go finding drugs now. Now we have an alternative. So we stick to this. That's what I'm trying to say. Yeah.
That is basically when we have to, that means I have to renew the guideline currently now, because interacting with you, it has shown that we need to improve more and more. So we'll go for it, ma'am. I will start all those things then. My next question, thank you for this, ma'am, first of all, and now we'll go for the next question. Ma'am, you have answered my next question also. By when should we give the general anesthesia? And but the question will be now, which one is better, Midas or propofol or thiopentol?
Now I'll test your knowledge a little bit. So I told you the side effects of midazolam. What is it?
Ma'am, the Midas is actually, ma'am, first of all, we give it to everything. So we shouldn't give Midas, first of all. Ma'am, the second thing is the reactivity. Actually, the T half is lesser than propofol, but it can cause other symptoms also.
So my only fear will be, so my only fear would be respiratory depression, because I'll be seeing that, I don't want the patient to have any more complications, right? So I would not go for Midas as a physician. Now you're telling me propofol. Now propofol has an activity of causing hypotension. So when a patient has patient presents to me with hypotension, right? If I give propofol, I have to again start the patient on NORAD. So then what's the use? But thiopentol as a dictum is safer, doesn't have that many side effects, and its T half is longer. So I would go for thiopentol.
A lot of times we see the post-status epilepticus patient admitted in critical care. How should we approach those electrolyte disturbances that we see in those patients? Like hyperglycemic hyponatremia is there, hyperkalemia is there, which can progress to cardiac arrest, and a lot of lactic acidosis are also there. Then how should we approach those patients?
So as I had told you earlier, that it's very important to know the pre-existing condition of the patient. So since you are talking about hyperglycemia as well, I just want to know that, so when a patient comes to me, the first thing I would know if the patient is diabetic or hypertensive. So a patient who goes into hypoglycemia because he's ingested excess amount of OHAs. I mean, I need to know all the possible treatment the patient has been on. What is the pre-existing comorbid condition the patient has? So before you check for the electrolyte, take a proper history is what I would suggest. Second is, it's a dictum and it's a norm, especially in Harrison, they have mentioned that the electrolytes that increase are everything except for potassium. It's a dictum that actually they say that within the first 2 hours of post-ictal state, hyperchloremia is very, very common. Hyperphosphatemia increases, not chloride. Chloride doesn't increase much actually. Potassium and chloride doesn't increase. Phosphates level increase. Sodium increases. And it can also cause, I think hypercalcemia also is seen in such cases. So you have to keep an eye on these electrolytes. So sodium, magnesium, calcium, and phosphates. These four are very important electrolytes to be kept in mind. And simultaneously, as you guys know, that if the patient is, has an electrolyte, you always have to correct it. Now, each electrolyte correction, you must be knowing that if the patient is having hyponatremia, then you don't give a fast, you depends on the level. So only a patient who shows about 110, you give stat correction. If the patient is 123 sodium with milliequivalents of sodium, the patient comes to you and the patient is conscious oriented, you don't start treatment. You don't give any form of any fast treatment. No, you should not do it because it causes cerebral edema. You should never do that. Similarly, in magnesium, if it's low, you give magnesium sulfate like a stat dose. If it's calcium gluconate correction, because that is also, you keep asking me, right? Because in hyperkalemia also, patient has ECG changes, and then and what is the main important thing that you see in ECG changes? You see tall tainted tainted T waves, basically the peak T waves. So that is an indication that the patient is in hyperkalemia, right? So then what do you do for hyperkalemia? The 3 important things that you do. You give patient Astelin nebulization, right? You give calcium gluconate correction, right? And you give, what do you give? In 5% dextrose, you give 6 units of insulin stat you give. So these Yeah. So why are you doing this? Because you're trying to push the potassium inwards. You're trying to push the hyperkalemia. The potassium is extracellularly. You're trying to push the potassium intracellularly, right? So these three dictums tries to push the potassium inside intracellularly, right? So the correction. It's just that in status, it's not about the correction. It's about when do you catch it. I have seen this patient, the case that I had told you earlier. She had hypernatremia. That reminds me, she had hypernatremia. So what we did was, what is the treatment of choice for hypernatremia? You don't do anything. You just put an RT and you give her free fluids. You give free water basically. Free water is what is the treatment of choice. And any NS that has, you make it half. If you're giving 0.9, you make it 0.45. That's the treatment. So there's no dictum as such that you have to there is a certain amount of way to correct electrolytes in status epilepticus. It goes for any form of treatment. I mean, if a normal person also who's not throwing seizures, of course, that's the same treatment. So there's no dictum as such. But yes, I would stress that the 4 electrolytes that are impaired in post-ictal stage is calcium, sodium, magnesium, and phosphate. Phosphate very important because phosphate plays a very important role with calcium. So you have to keep that in mind. And the book says, I have not seen potassium increasing post-ictal stage. So potassium and chloride are usually normal. So
last week we have seen a patient with hypermagnesemia and hyperphosphatemia. So ma'am, if the patient has both, because if the patient has both low hypo, magnesium and phosphate, then we first correct the phosphate and then go for magnesium. But in terms of hyper, which to correct first?
So you had hypermagnesemia and hyperphosphatemia, right? See, in my setup, what we do is we go for magnesium first. Magnesium is the correction is very important because, as you know, magnesium also causes toxicity, causes a lot of, OBG maybe must have studied that it causes a number of problems. So yes, you should go for magnesium first. Yeah. Phosphate correction is very important. That's what we do here. We go for magnesium first. Hypermagnesemia.
Oh, yeah. So thank you very much for enlightening us in the terms of status epilepticus. It was a great session, and for all those clinical practitioners and students, ma'am, this was actually very good session, ma'am. So, I guess thanks to you.
Thank you.